shot.
You're still good.
And all the way over?
Mm-hmm. And all the way over.
Fine, great.
I mean, I'd avoid like the last few inches, but.
Okay. All right, go ahead. Are you already recording?
Yeah.
Oh, all right, there you go. Okay, there's two things that we're going to cover today, and one of them I forgot to put on your
handout
thingy, but it's really useful, and I think it's going to help some of you depending on how you learn. So this is a different kind of concept map than the concept map that you guys are going to have to do for your patients. This is a patho concept map. Okay, so a lot of times you guys are struggling with how to tie things together. How to make that linkage make sense, because you're sitting there being like, okay, you know, the person has acute kidney injury with this, acute kidney injury with this, acute kidney injury with this, and you're like, okay, and then they have hypertension with this, hypertension with this, hypertension with acute kidney injury, and it's hard to figure out how to describe that, put it into words. So there's this really great thing, it's called a Patho concept map, and it's pretty, don't think of it in the same way that you think of your concept map that you guys have to turn into me later, because that's kind of structured differently, and I don't really like that. But this one, it's kind of about the original pathophysiology, and then through a few layers, what signs and symptoms that you see. So let's take a patient. Okay. I guess I'm just going to make one up. Let me think of the last patient I took care of. Okay. All right, we're going to take a patient who is encephalopathic from advanced liver disease. Okay? So this patient originally had Hep C. Okay, so that's their underlying diagnosis, right? Because of the Hep C disease, we see liver cirrhosis, which is different than just infection in general. Okay? Because of that liver cirrhosis, there's a lot of things that happen. The first one is the liver's not doing what it's supposed to be doing, and there's a few important things that the liver is supposed to be doing. One of the things the liver does is it filters out ammonia. When you have really high levels of ammonia, what happens? You get crazy. People get crazy on ammonia.
Really?
Yes, that's why people are encephalopathic. So elevated pneumonia levels equals encephalopathic. Equals crazy. Okay, this is ammonia. NH4 is ammonia, just in case. Okay, so we're seeing somebody who's crazy, all right? But there's a few problems with poorly functioning livers, besides the fact that your body's not filtering out the toxins that it's supposed to, which is mostly the ammonia. What else does your liver do besides filter out toxins? Huh? It does gluconeogenesis, sure. So it's responsible for storing fat, storing elevated glucose as
vitamin K. Right?
You're sort of there. Okay, yeah. So
body.
So we have decreased glucagon synthesis, which leads to elevated that was terrible. I moved right through the word. Sorry, guys. All right, so the liver is responsible for making glucagon synthesis, so storing all of your blood sugar that you have excess in your body when you're in a time of excess. And so you get elevated blood glucose levels, and you have a pancreatic overload. So you're asking your pancreas to do too much. Mm-hmm. So what happens when your pancreas gets super cranky? What does it stop doing?
It's producing.
Uh-huh. Which means you have diabetes.
So that's why my Hep C patient had diabetes.
Okay, so we've got glucagon synthesis, we've got getting rid of ammonia toxins. What else does the liver do? It has something kind of along the lines of vitamin K, sort of, but what is more important when you're trying to clot than vitamin K? Clotting factors. So, say it. Say it.
Clotting factors.
Say it. So what does it not do?
Oh.
What do we don't have?
What do you mean?
So no clotting factors, right?
That there's something more. Like,
What does that mean?
that
Yeah, bleeding
you're
or
gonna have
bleeding
increased
risk.
bleeding.
So most often when people have like low ability to clot, a place that they bleed a lot is their GI tract. So you're gonna see GI bleeds, right? GI bleed can lead to melena. It can lead to, are you ready for this? Hematochezia. What?
Ew.
Oh,
Okay.
that nurse today, he was like, have you ever seen someone vomit blood? It's really cool. And he was like, don't freak out. I was like, okay. It was like out of nowhere though. So that's what it's called?
It's called
It was like,
hematochezia,
they will projectile vomit and hit their toes.
at least, if not the wall, because your body does not like to have blood in its GI tract. We have evolved past raw meat. Okay, so melena, hematochezia. Coffee ground emesis. Quick side note, what's the difference between hematochezia and coffee ground emesis? These are both emesises.
I'm sorry.
One's darker, this is bright red, and how coffee ground literally looks like coffee grounds. And by the way, this is the medical term. There's no like fancy Latin word for coffee ground emesis. It's just coffee ground emesis. So any guesses on what the difference between these two are?
One's lower, one's
Go ahead.
the coffee ground would be lower, right? Upper. And then
Decide.
okay, well, okay, I was thinking.
Think about it.
Okay, the brighter one, the hematochezia, would be lower
Why?
because it's closer. I don't know. Can't explain why.
Anybody else can explain why?
It's excreted faster, so it doesn't have enough time to like get old.
Nope.
No?
Jen, anything? Okay.
It's missing something.
Hematochezia is bright red blood, and that means that the blood has not been digested, which means it is really high up in the GI tract, because remember, you're vomiting. If we're talking about pooping it out, that's the opposite. But if you have like esophageal bleed that's leaking into your stomach, and then your stomach says hell no, and then it makes you vomit, that is going to be pretty bright red, right? You're going to see bright red blood. Coffee ground emesis is blood that's been digested. When we digest blood, it tends to go black, right? So coffee ground emesis is digested blood. So this is blood that has maybe made it through the stomach and into the beginning of the small intestine. Then your body's like, wait a minute, no, and then it backs back up and comes out. Okay? So this is a lower GI bleed. This is an upper GI bleed. This is like basically, hematochezia is almost always esophageal varices, which, by the way, comes from liver cirrhosis too. So we can get there with that too. Via esophageal varices. What are esophageal varices? Esophageal varices are the veins in your esophagus, right, get swollen because your liver has stopped being able to filter blood through because it's ulcerosed. So when that happens, you get something called portal hypertension. We'll write that right here. Because the blood that's trying to go through the liver, it's just not going through. And so it's getting backed up. So it's getting backed up here, and one of the only places it can really go is into the varices of your esophagus. So they get super swollen, and then anything can cause them to burst, and you can have burst varices. It can either be a slow burst, and it'll just turn into like something down here, hematochezia. If it's a fast burst, people will bleed out. This is one of the common ways that people bleed out from this. You can die very quickly this way, because the majority of your blood that's trying to return through your liver, which your liver filters all of your blood very fast, is coming out through your varices instead. Okay, where were we now? We were on something else. Melachizia. And then coffee around emesis is just regular GI bleeding, right? So this is all because you don't have any ability to clot stuff off, so you're just at increased risk of bleeding everywhere. Besides clotting factors, tell me a little bit more that has kind of to do with clotting factors and kind of to do with anything that the liver does. It's kind of a weird question, I know. What else does it make or process besides clotting factors that are the same kind of thing as clotting factors?
Okay.
Protein synthesis. Your liver is the primary spot for protein synthesis in your entire body. So anytime you eat anything, it has to go to your liver to get broken down into the building blocks that we need to be able to build all the things we use with proteins, right? So when it sucks, you have low levels of protein. Okay? When you have low levels of protein, that's bad. Why is that bad? Not only are you not being able to build all of the awesome things that you need to make protein with, but low protein in your blood leads to low oncotic pressure. Does anybody remember what that means?
The pulling pressure
Uh-huh.
in your blood.
Yes. Perfect. So, your proteins, because they're net negative in their charge, they actually hold on to water. So their job, part of their job while they're floating around in your system before they get delivered to whatever cell needs them, is to keep water inside your blood. So if there's not enough protein in your blood, you don't have that oncotic pressure, which means what happens to the water? It leaks out into your tissues, exactly. So this drop in oncotic pressure leads to peripheral edema and ascites.
Oh yeah, it's huge.
Right, which is why a lot of like alcoholic dudes who've been drinking forever, who've basically killed their liver, they look super scrawny in their arms and legs, and they have like this huge pregnant-looking belly that is full of ascites because they are not making any proteins anymore because their liver is so cirrhosis by alcohol, or Hep C, or autoimmune like liver hepatitis, whatever. Okay.
And they can pull that fluid off. Right?
Yep, we can pull it off.
But then it just builds back up.
Just builds back up because more fluid is leaking. So you can actually have somebody who's, wait for it, vascularly depleted and peripherally endematous, right? Somebody who can be hypotensive and have way too much fluid on board at the same time because all of their fluid has leaked out of their veins where you need it to be able to perfuse, and it's just hanging out in your belly and in your periphery.
What do you can give them to get their fluid back into that?
So you can treat them with albumin, which is IV protein, basically, and that will briefly increase the osmotic pressure in their blood, pull that fluid back out of their periphery into their blood, and they can perfuse with it. The problem is you're treating the symptom, not the problem.
Right.
So you can treat the symptom for a little while, which will help for a little while, but it really doesn't do a lot. Depends on like what your time frame is. If they're like crashing, give them some albumin. But if like they're okay and you're just trying to figure out how to make them better, albumin's not going to do anything. All right, so let's see what else we got with liver cirrhosis. So you can see how we're landing. I guess these two are kind of the primary diagnoses, right? The Hep C-induced liver cirrhosis. But you can see how you have the pathophysiology leading to all of the different things that are happening to the body and then landing in all of your symptoms that you're seeing. So what you see with your patient is you're seeing peripheral edema and ascites. You're seeing bleeding of some kind or another in some way or another. You're seeing elevated blood glucose levels. This is kind of a double-edged sword. And you're seeing, those esophageal varices. Oh, and you're seeing crazy. Don't forget crazy. Okay? So this is the concept map. This is how you can understand the concept of kind of all of the things that are happening. But, okay, let's mix it up a little bit more. So let's say that this patient doesn't just have liver cirrhosis that is leading to all these other comorbidities. They've got a couple other actually unrelated things. Let's throw hypertension in there. Because we know everybody loves hypertension. So how does hypertension play a part in all this stuff? Okay, we have, where are we? Okay, exactly. Overall, hypertension is going to increase your portal hypertension. which is going to make this process even more exacerbated, right? What do these two things often do together? They with the kidney, kidneys. Kidneys. Kidney stones. You guys don't watch Friends. You don't know what that is. Okay. Kidney damage. Which leads to elevated BUN and creatinine. More peripheral edema, more fluid overload, right? Oh, and then of course, electrolyte imbalances. What are your two electrolytes that have the most to do with kidneys? Potassium, yes. Actually, not sodium. Sodium's kind of it, but phosphate. Your two kidney numbers are your potassium and your phos. Okay? If somebody's in kidney failure and they're not filtering out the way that they need to and regulating electrolytes the way that they need to, these are the two that are going to be super elevated. And how elevated these two are is a better indication of how critical that kidney damage is than BUN and creatinine. Because some people who have like chronic kidney disease live with a BUN and creatinine that's like pretty high. And they're like, okay, I mean, they're fine. But a potassium that's out of normal range will mess with your heart like that, right? You cannot tolerate, potassium's got a pretty narrow range if you haven't noticed. And when it's out of range, high or low, bad news bears. Same for phosphorus, okay? So these are your two numbers to get an indication of really how bad a kidney situation is, all right? So now we're talking about labs that we're seeing. While we're on the subject of labs, what other labs are we going to see here? From this stuff over here. There you go. Low H&H. What else? How about from this one? No clotting factors. Sure. Elevated coags, which is PT, PTT, INR. And then what else? What other, I mean, how does the liver affect the coags? It's not heparin. It's not killing clotting factors itself. What other thing gets generated and produced in the liver? It's a component of blood. It's not red blood cells. Platelets. All right, so then we're going to see lab numbers that are going to show low coags and low platelets. All right? I don't know why I stop circling things sometimes. You guys are just going to have to figure it out. Do you guys want to throw some comorbidities, more comorbidities in there? What else do we see a lot with patients besides diabetes and hypertension? Let's talk about his heart. We haven't really talked about his heart much. But guess what these two things are going to do besides damage the kidney? Well, almost. There's a step between this and heart failure. Like 8 of your patients.
Coronary artery.
There we go. Right? Viscous blood, sticky, vessels that are getting stiff and unhappy, coronary artery disease. Coronary artery disease puts you at risk for 3 major events that can kill you pretty quickly. What are they? MI? I don't know why that's, well, this is just a really fat eye. MI. All right, stroke. What's the third? Slightly less crisis, but still pretty acute. Elizabeth, you could guess at this one.
MI, stroke, any kind of, would it be like, this is totally a, wouldn't it put you at high risk for any kind of clot? So like even like a DVT?
Sure.
Because if you're gonna have coronary artery disease and have like plaque buildup and stuff, then you're gonna have
Clots. What did your patient have the first week? Jessica.
She COPD. Wait, no.
Hypertension.
You said it.
Hypertension.
Heart failure.
Uh-oh.
oh.
Acute heart failure.
I was thinking something much
smaller than that.
Yes.
Yeah, I
So,
wasn't thinking such a big category.
so if it's harder, if your vessels stop being flexible and your blood becomes more viscous, you're going to increase that systemic vascular resistance, which is going to force your heart to work really hard. Huh? You've already got that hypertension, so your heart's working really, really hard, and the vessels that feed the heart its own blood are also sucking right now. So especially if there's any kind of MI, but even if there's not, your heart can start failing. It's just going to start backing up. Then you're going to see that heart failure. Okay, that can be long-term or short-term. It depends on how bad everything looks. All right? Interestingly, if you notice, this patient is at risk for clots and bleeding. Totally possible. What usually happens is these clots are little tiny microclots, and they'll clot in the, like in DVTs, they're going to clot in little places, right? Because some clotting factors are still happening. And they're clotting because of fat emboli, right? Not because of clots, but like because of non-clotting factor clots, right? But they're also bleeding, so you're going to get somebody who can shower microclots and be at risk for really high risk of bleeding. Okay, so this is a mess of a patient, this poor guy. But I see this like every other day. Usually it's alcohol, sometimes it's hep C, sometimes it's autoimmune or non-steatohepatitis that is completely not because of a behavioral factor. Sometimes it's just hereditary poor liver. Okay, so if you have a patient who has a lot of stuff going on, I encourage you to make one of these, because this is going to help you explain every single peripheral sign and symptom that you see. Okay. Oh, okay, let's throw, most likely, you're going to see AFib here, right, which is going to be another heart symptom. This is also going to lead to peripheral edema, which we're about to talk about in a minute, right? So you've got peripheral edema from here, and peripheral edema here. Okay, so if you see peripheral edema, you can explain out why. Yep. Well, if they're not screwed, they're just sick and they're at risk for being sick, right? Depending on how bad all of these factors are. If they're well controlled, they can be comfortable and happy and relatively healthy.
True.
So this is a patho concept map. It's a little messy. If I were to like turn it in, I would probably organize it a little better. But this is a great way for me, and maybe for you too, to understand the why and the how of what your patient's here for, what that can lead to, and what kinds of assessment and signs and symptoms that you're seeing in labs and in your physical assessment. All right? Mm-hmm. That way you're having a really clear idea of like what your patient's actually facing, and you get a chance to kind of talk it out a few times, right? If I had to put this in a paragraph, all right, hang on, let me think about this for a sec so I can say it right. I would probably say, due to an infection with hep C, my patient developed liver cirrhosis, which led to peripheral edema. You can go through all of these things. Developed liver cirrhosis. They were unable to filter toxins, which led to encephalopathy. They were unable to produce clotting factors, which led to the GI bleed that we saw, shown by the coffee ground emesis and the drop in H&H that we saw, including the drop in platelets, also their coags below. That liver cirrhosis also led to increased risk for diabetes, which they may have had because of this or already had. The diabetes plus the other comorbidity of hypertension led to kidney damage, giving another explanation for the peripheral edema, as evidenced by the elevated BUN and creatinine, K of 5.8, and phosphorus of 6.8. Okay. Because of the damage in the vessels due to the hypertension, the diabetes, and the poor quality of the patient's blood, he developed CAD, which led to an increased risk for clots, which could lead to, or if we decided he had one, which led to an anterior MI, which left that patient in AFib for the rest of his life. How many sentences was that? 4, 5? You can say it fast like that. You can say it in a little more time. But I don't know about you, but I tend to, this I like. This makes sense to me. I'd probably neaten it up again because I'm a little meticulous about this stuff. But this is a good way for me to understand why I see what I see with this patient, and a good way for me to have a tool to explain it with. So, for your patient reports. Number 1, if you're having trouble making a linkage statement, or if you're having trouble seeing the things. Now, a lot of times patients can have comorbidities that kind of have nothing to do with each other. There just happen to be different hereditary or behavioral lifestyle things that came in. Like if somebody's got COPD and they have diabetes, there's not a lot of links to that between those two things, right? So you may not have very many links between the comorbidities, but those comorbidities of a sedentary lifestyle, poor diet, and difficulty breathing, you can start to see why some of the morbidities themselves and the effects of those morbidities can start crossing into worse health outcomes for your patient, right? So, number 1, if you're having trouble with linkages, make a concept map, even if it's just scratch paper for yourself. Number 2, if you like your concept map and you know that you like to make things for Rachel that makes Rachel happy, you can turn in your concept map or your Patho concept map for correction or as additional points for your patient report. Okay? It doesn't have to be neat, but it has to make sense. And if you do turn it in, I'm probably going to have you sit down and explain it to me, unless it's wicked obvious. I just said wicked. I haven't said wicked in like a decade. Anyways, I strongly encourage you to use this concept map idea. I find this way more useful to your understanding of your patients than the concept map that you actually have to turn into me. Okay? Questions? Does everybody have a copy done? Yeah.
No, this just kind of. Now it's just kind of confusing me because remember I was telling you about earlier with the obstruction. So.
The bowel obstruction?
No, BPH. So I feel like that fits more in the center because that can cause the acute kidney injury and that can cause urosepsis.
Mm-hmm.
So can that be my primary diagnosis instead of the
It can, if you really wanted to. I would accept that.
Okay.
I think urosepsis
It's
is going to be the
confusing.
majority of the signs and symptoms that you see, and it's also the reason that he's the most serious reason that he's here. But I would say if you're looking for like the root cause, this would be where your BPH would go.
Okay.
It would be at the center. Yeah, you can. That's fine.
So you put your BPH there, and then.
So she would put BPH
and
here,
liver
and
cirrhosis
she
would
would
be
write.
your sepsis.
She would write obstructive hydronephrosis, which would lead to a UTI, which would lead to sepsis, and then all the stuff that you see with that.
He has a few cysts in his kidney, so I think that's.
Then you can
why
put
he
that
has
there
the
too.
obstructive hydronephrosis.
No, it's the
No,
BPH.
it is BPH. Oh.
Yeah. The cysts in his kidneys, unless they were in his ureters, wouldn't obstruct anything. They would just make it more challenging to filter blood through.
Okay.
Question.
So for nursing diagnoses, we learned that if it's a risk, we don't have as evidenced by. Is that?
Yeah,
want evidence
officially that's the case, but
Okay.
you have to have evidence to support your nursing diagnosis. You can't. I mean, everybody's at risk for skin integrity here, right?
Right.
And if that's the one you choose, I want to know why you think like Jessica's patient, Ms. Coleman, who a couple of you have had, she's at serious risk for skin integrity issues. She also has skin breakdown. So,
It's already impaired.
right, so you would just say like impaired skin integrity, right? If you choose a risk for, it's fine if you don't put it as evidence by, but I would prefer it if you shared with
just
me.
so that I have the.
I mean, unless there's no evidence for it. But if there's evidence
there is.
for that risk, is there evidence for them to actually have that diagnosis instead of the risk for it? You know what I mean?
Mm-hmm. That makes sense.
Okay.
My primary.
Do you want to stop that for a sec, save some space, and then I'll erase it?